This is gone.
Yeah.
So good afternoon, everyone. This is our fourth session of the Genomics Gupshup. And I think our aim is to be able to get everyone to understand genomics in a simple conversational manner. And we are very, very delighted today that we have Dr. Rupinder Kler, who's not just a medical doctor, but she also has a PhD and she has an MBA. So she sort of put all the skills all together. And it's a very unusual combination that we find in India, especially. I do know someone else who has a similar skill set, and she's on my board, Dr. Anula. But I think it's a very rare combination that you have, and you have been in many diverse fields. So thank you very much, and we are very looking forward to having a fantastic discussion with you. I think people want to understand genomics and genetics, both the medical professionals as well as people in general. I think there's a lot of air of mysticism around genomics, and I hope that by conversations with experts like you, people will start to understand and demystify this whole thing. So
thank you.
So I'd like to start off with a question which is about your background, right? You've gone through a very interesting background. I just wanted to know what inspired you to become a medical doctor in the first place.
Actually, my father's sister, my aunt, she is a gynecologist, and I used to look up to her for that. Although I was always a very average student and was not a very serious, focused, or a very into studies all the time. I was always into playing, but I was always told that I should be like her. So she was my first inspiration, but then she left for UK. She did her gynecology there, and then she moved to Dubai. But I pursued it because I just felt that medical should be there, that way. So when I joined, I had to go through a lot. So all these, at our times, they used to be all dead bodies, cadavers. So these were not very, healthy for your mind. But then studying was also one thing that was so important every day, It was an everyday thing, and a person like me who was always playing was not a very great feeling. Like you had to study and then not understand. So like initially, when we do our +2, things are different. But when we come for the medical thing, it totally transforms, the education, the transformation as such that anatomy and physiology, especially anatomy, it's one of the most terrible subjects which we come across. So we have, I didn't have any clue from where to start and from where to finish. So half the time I used to be lost, and I think everybody would be, but I was one person. I can always say that I was lost. And then the real thing came that no, I have to do it. By hook or by crook, I have to get my 50%. My father is not a doctor because doctors help their children. But so how to go about it? And my father was a very strict person, telling me that I will never go, help you out with any other doctor, or I will never go to any physician to say that help my daughter. So you'll have to struggle on your own. So one thing, the struggle started right there. And I knew I had to go through something or the other, which was not very cool. And my parent college, they would laugh and things were like that, some interesting, some not so interesting. So that's how I finally, when I did my second year, so the determination grew when I developed my first cancer. That was Hodgkin's lymphoma. And I diagnosed it almost all by myself, because there was a tumor, a small little tumor in the neck area. Let's be a little non-doctor here. So it was in the neck area. And so this tumor was growing. It didn't hurt anyway, but I used to get fatigued after my classes and everything. So then I got, we got it tested, and it was Hodgkin's. So I went abroad to the US that time and got myself treated, and I was perfectly fine after 6 months of my radiotherapy. But then my determination grew that I had to do, I had to be very good in my medical in order to, because it was so sudden. Maybe I didn't even know as a student, as a younger student, what to do about it. Then after that, again, things were very nice. I got married, and I had a baby right away. And then I was not supposed to, because the doctors would know the laparotomy. The laparotomy, they take out your spleen. Now the spleen is the reservoir for combating all infections. So I was given a vaccine, but then I waited for 5 years, and then I restarted. I joined pediatrics, but the pediatric part was not very great because I was having infections again. So actually, that is what initiated that. How am I going to be a physician? How am I going to do all this? I mean, I am left with nothing. So, that is my journey. I still finished my MBBS, and then I had to take breaks. And then after that, somebody telling me, okay, you do a MHA, especially when we were in PGI. They said, okay, why don't you, if you are having infections, go in for hospital administration. So I went in for MBA. So that MBA taught me the motivation, the leadership skills, the organizational psychology, the behavior of an institute anywhere. And that was very important. And then understanding the finances, which doctors are not good at all. So I understood, okay, when we have a project, how to evaluate the project, how to implement a project, is it feasible or non-feasible? So I did everything wholeheartedly. The importance was not getting a degree. The importance was understanding the the administration, the management, MBA as such, how to start a business, and so on and so forth. The business, I felt that medical also could be a business. It's not like it's a service industry per se, but business has to be, ethical. It should not be unethical. So I have always had a code of ethics, and I've always believed in that. So my belief, I don't care. I always do that on my own, the belief part particularly. And so my MBA was left a little in between, the last part particularly. And the PhD just came by chance. It was like, what to do, medical, yes, PhD.
दो degrees हो गए एक और.
Yeah, it was not degree per se, but yes, it was associated with medicine.
Correct.
So I pursued it. I pursued, okay, I have to go in for a PhD. If I cannot do medical, I am going to do my PhD. Our research and patients will go together. So if I'm unable to look after the patients, I'll ask my doctor or a colleague to look after, and then how to go about it. And in fact, in between, I also learned a lot from my father-in-law, who was a principal of Dayanand Medical College and Hospital, and he taught me the history taking, the clinical examination. So I was quite well versed with all that beforehand. So, but then again, the quality of being a physician was not very great, because I would develop infections on my own, and I could not pursue the patients or follow them up at all. So what was the use? So I started off my PhD in 2004. In fact, I was enrolled in 2005. So I started off after my MBA. And then it was Professor R.C. Sopti, who was a Vice Chancellor of Punjab University. That time he was a head of biotechnology, but then he was about to become a Vice Chancellor then. So he was very much, he really helped me in all terms. I don't know if God exists or doesn't exist as a scientist, I cannot say. But yes, there's a power that pushed me that side. And my focus and concentration, he appreciated so much that I feel every individual needs that appreciation at one point of time. And he gave me that. He gave me the courage to, write papers, to write thesis on my own, to make up things on my own. So I was quite serious about doing all this. And so I would, work in PGI, come back, work in my lab. I would come in the mornings because I had time then. I would, run and get my child, get ready for school, leave. So I was a hands-on person till night. So hard work was one thing that kept on. And then after the PhD, through the PhD, I again developed hard block. And so Professor R.C. Sopti very well knows about it. And my medical supervisor, my mentor was Professor K.K. Talwar, who was director PGI then. And so he was the head of cardiology in PGI, and he was my mentor. And he operated on me, and he put the pacemaker in PGI, and they were like shocked how things, were progressing for me. But then I never gave up. So again, after 3 months of my struggle, I rejoined as for the fundings and everything. I joined projects, and because that was very necessary. And so that is how I progressed. And finally, I focused, and my PhD finished. So that was, yeah. So, and then I again, after the PhD, I didn't feel very complete. And I appeared for my geriatric medicine. So geriatric was a very a newer branch which deals with old age. So, old age issues are different than the younger medicine people in medicine. So I did that, and it was very interesting because it involves community medicine. It involves going to their houses, being empathetic with them, understanding their needs, how their the joints are affected, how their Alzheimer's is setting, the dementia, the memory losses. There are many issues which they have much more differently than the younger people as senior citizens. So I learned that as well. So the empathy part was always in me. And so I really enjoyed the journey despite my challenges, the health challenges. So that is how I finished my geriatric medicine and started practicing, as well as doing my research in PGI.
So do you think, I think maybe, the fact that you've been a patient through this journey as well, I think that probably adds a little bit more dimension. I think it probably also inspires you to know yourself a lot better. And I think, understand what other patients are going through. So I think it's a very inspiring, very, very inspiring journey that you've gone through. And I think, today I feel that a lot of the amount of research that we do in India is still limited, because I think we see medical doctors as a separate silo, and the community that does research as a separate silo. And I think that connection, that cross connection, is probably the most important element for us to get to that point where we can start doing better research in India. So do you think, since you are one of the few doctors who moved to the other side, if I can say that, how difficult was that journey? Do you think it's easy for medical doctors to understand, let's say, genetics or research, or is it a very different experience? And do you think there's a way to bridge the two?
See, I happened to do a certificate course from ICMR, Indian Council of Medical Research in Lucknow, SGPGI. So there were doctors who were doing medical genetics, and now as such, because the medical genetics had started, so they were doing their MD, DNB, or there are different degrees, and some were doing their DM also. So, but I found that those people, they did have, but the fields, they definitely knew the genetics, but it was very limited to single gene disorders or limited to those syndromes which are already isolated in the world. So there was nothing new. So when we go into a new direction, or when we do go into a new career, or we do go into a newer place where, especially medicine, like I like medicine, so I never wanted to go in for any other field. But when we going into medical genetics, I didn't find it very interesting because it was all about pediatrics, the syndromes associated with pediatrics, which were already there and which we were reading when we gave our entrance exams. So I really didn't know anything very special we were doing, even with the whole genome sequencing or with the exome sequencing. What were we finding? So that was not interesting for me particularly. And but yes, there were people who were understanding, doctors. They were understanding technology, and they were understanding, but execution part was not there. How and why? Those were the questions still unanswered. How to go about it? If we are talking about mRNA, why we are talking about it? It was not that. For medical genetics, it's a syndrome, and we are talking about either diagnosing it and finding. Pharmacogenomics in 2017 was not very great. I'm sure it's not very great now also, because I joined then, I did my training part there. And so if pharmacogenomics is not there, the drug development is not going to be there along with the genetics. So the pathways are not, so we generally go in for the pathways. So the research has to be there. Without the research, there's no use of a doctor going in for medical genetics, I feel. I mean, it's my very personal opinion. And yes, there are many syndromes which are, multiple syndromes for pediatricians. So pediatricians probably could do with medical genetics, because sometimes they have some issues with the diagnosis. But other other fields, they don't really require medical genetics as such for diagnosing. And especially sometimes you can say neurogenetics, the newer fields, or even sometimes when we are thinking the cancer, yes, there is certain pharmacogenomics in cancer, where the cancer diagnosis and the cancer drugs are helping us out. But apart from that, the cancer, maybe that is helping with the defining the dosages also. But otherwise, very few drugs are there which are dosage dependent, especially the toxicity, the adverse events which are associated with a drug like, for example, warfarin, or drug like heparin, or those kind of things, where one same dose is given to one patient and the same dose is given to other patient. One patient bleeds, but the other patient doesn't. So those are, again, this is all pharmacogenomics, all genetics, basically. So we need to really do a lot of research in order to find out the pathways which control them, the basics of a severity of a adverse event or a milder event which is occurring.
So I mean, we are currently, for instance, doing like a product on on pharmacogenomics that basically looks at least all the more than 100 drugs that the US FDA has shown has a genetic marker. Right? Now, one of the things that you're mentioning is that we need to find out the how and the why. And clearly, I think more research needs to be done on the Indian population. So are there some examples that you've been involved with on the pharmacogenomic side, where we are trying to understand, some of the other pathways that maybe haven't yet been discovered? Do you think that we can do this in India in a larger scale? And will there be enough funding for that, both on the public side as well as the private side? And why should we do it in the first place, right? I think you mentioned some of that, but I think from a overall development of the country or otherwise, do you think that is something that is necessary?
Certainly. Actually, like I can give an example of the recent research which I did on COVID. So I have a paper too. So if you separately take these azithromycin, pentoxifylline, dexamethasone, together they inhibit or the COVID virus. So why? What is going on? So again, that is the molecular level. So what is happening at the molecular level is that as a azithromycin, this is a macrolide. Every doctor knows about it or a pharmacologist knows about it. And these are already drugs which are being used for different bacterial infections, but no one knows its antiviral effect. So the antiviral effect, which I found at the molecular level, and when I talk about molecular level, I'm talking about the cell level. And when I talk about the cell level, I'm talking about the endoplasmic reticulum. I'm talking about the cell wall. I'm talking about the cytoplasm. So what happens is mainly all the viruses because COVID is a positive sense virus. So the positive sense viruses, it comes directly to your cell. It doesn't need to, it automatically understands your protein, or it has a capacity to generate the same sort of a protein which your body has already been acting like the ACE protein. So the virus won't have any issue. Your body is not going to recognize that there's a foreign body. So what happens is it lands on the cell, the next to the cell, and it has the capacity to enter the cell because your body is allowing it to get into the cell. Now, where does it stop? The phosphoglycoproteins, or those proteins that are transport proteins, they are to be stopped. And azithromycin is an inhibitor of those phosphoglycoproteins. It doesn't let
it from
it doesn't let the efflux of the virus or any other drug also for that matter to go inside the body. So azithromycin has that role, although not without the side effects. Like as a clinician, I would want a ECG done for the patient to see the QT interval. QT is one of the ECG changes which we see where prolongation should not be there. Otherwise, the patient can die. So we always take care when we take our patients that this QT interval should not be prolonged. That is as a clinician. But as a molecular person, I saw that azithromycin at a higher dose, I usually take a high dose, and that at a higher dose was inhibiting the virus. And it also has an effect on LDH. It reduces the LDH, the lactate dehydrogenase. Now, the lactate dehydrogenase utilizes your sugar and converts it into energy, like the mitochondria, when we talk about it at the cell level. So that is what these enzymes are doing. So enzyme has a major role in mRNAs also, in development of vaccines also, in development of drugs also. So the research where you are questioning me was, even when we are talking about pentoxifylline, FDA banned pentoxifylline. And when I see, or when I've seen the patients since 2 years, and also the studies which have been going on since long, even for COVID now, people have isolated pentoxifylline as one of the very specific immunomodulators for COVID. But I generally am not talking just for COVID. It's a very interesting drug, I must say, that it has multiple pathways which this drug takes. This drug acts as an antifibrinolytic. It doesn't let the fibrin collect and make clots. So you can say it has an antiplatelet effect also. It also has it's also used in DVTs, intermittent claudications for doctors particularly. And so the patients can walk. It also has an effect on the alveoli of your lungs. It helps in cellular respiration. It helps in oxygenation. So it generally goes through the microvasculature, which COVID gets affected. So COVID makes microclots. So it doesn't let those clots happen in the microvasculature of your body. So that's how it helps. Azithromycin doesn't let the virus go inside your body. Just in case you are a severe patient and the virus still enters your body, the pentoxifylline looks after that. It doesn't let the virus destroy your or any organ, or it leads to bleed in disseminated intravascular coagulation, or it happens to be a clotting mechanism, coagulation cascade, which it affects. So that is how pentoxifylline acts. Dexa, again, it has an immense effect. A low dose of Dexa has an immense effect on your C-reactive proteins, which is an acute phase a reactant. It's an inflammatory marker for an acute infection. So that's how TNF-alpha is affected. So I saw that all of them get stabilized within a week. In a severe case also, but in cases of Delta, what was happening that once a patient got okay, after 15 days, he would develop a little again. So a couple of times I found very severe patients having mild pneumonias. So the mild pneumonia was that in those cases, I started giving Monosef, which is cefotriaxone. Now, cefotriaxone is a interleukin 10 regulator, indirect. It acts on macrophages, and macrophages make IL-10. So it is an indirect. So people have studied another antisepsis drug also, elinastatin. And so those kind of drugs I have not used. I have used this and with good effect. But I never leave pentoxifylline and Dexa. And then for diabetics, we were using metformin. Again, these are all phosphoglycoprotein substrates or inhibitors. So that way, the phosphoglycoproteins at the cell level have affected the efflux of the virus, which we are trying to inhibit. So this is my research all about. And then the patients really don't need any other hospitalization or even extra oxygenation. The normal oxygen, if their oxygen falls to 89, 85, and I make them exercise and do things like whatever is needed. So it's a full management, which I do with the patients. So, but at the cellular level, yes, certainly, it's very, very important to understand that these drugs can be studied even for other viruses, even for other issues like itraconazole, I gave for angiogenesis. Angiogenesis is making new vessels. Angiogenesis, growth factors are there in our body, which make new vessels. So itraconazole acts on the vascular endothelial growth factor A, and it inhibits vascular endothelial growth factor. And it's very important as an antifungal agent, but it's been seen that it is also effective in cancer. It doesn't let newer vessels form. The cancer nutrition is stopped. And pentoxifylline, along with itraconazole, has an effect on fibrosis of the lung. And I've given to my patients. So
how did you think about, like, so you basically looked at the pathways of different drugs and then basically said that, you know, by looking at the molecular effect that it has on different things, that this combination could be a potential, useful thing for my patients, right? Because a lot of this was obviously a new disease that none of us were previously had any SOPs for in many ways, right? So that's quite fascinating. But one of the things I remember in our previous discussion, we also mentioned that, and I saw that you were also associated with the Ayurveda hospital, for instance, right? So how important do you think that, when you look at a patient and you look at an overall at a holistic level, how important are like dietary modifications? How important is it to look at every aspect of that patient rather than treat a specific problem? Because a lot of times people end up going and getting treated by a super specialist without looking at it from an overall perspective. So what are your thoughts around that?
I personally feel that yes, there is a genetically You come up with patients who are milder, moderate, or severe. That is again genetics. But then they may not have any disease unless and until they are stressed first. The stress is mental stress or the physical stress. Physical stress is very much connected with your mental stress. So because your mind and body have to be in control. And when we talk about meditation, it hasn't to be a superficial meditation. We really need to be happy. And that serotonin has to be in our body in order to be happy. So the real happiness doesn't need dependence. It has to be within first. And secondly, everything has to be balanced. Your mind, your food, and your body. Everything has to be balanced. And determination that yes, you're going to live and be strong. That is very important, what I feel. And when I talk about Ayurveda per se, I'm talking about all these herbs. I only know that, okay, they are flavonoids, which are antioxidants. And these have played a very major role ever since, like berries or apples or nuts or, omegas, all of them, they have a very major role. And even for the younger people, younger generation, where there is a lot of borderline personalities nowadays, because all the stress is too much on every parent and every child. So what we are doing is we are making a stressful society. That is why there are more cancers, there are more heart diseases, and there are more COVIDs. Otherwise, even the COVID can be contained if we know that, yes, it doesn't really matter. It's okay. The drugs are there now. We can act. So that is what I tell my patients, that the drugs are there, but then you have to be not assessing the blood test. I'm there to assess. It's not you, it's me. I'll let you know if it's important, where it is important, how much is it important now, because otherwise you will be stressed out, and you will be, and stress actually aggravates any underlying issue. And be it a virus, be it a bacteria, or be it a cancer, or be it a heart disease, and ABC of anything. So that is what I always tell, that diet includes a healthy diet, and that too not an obsession that yes, you are going to focus on that only.
Yeah.
So that should not be an obsession. But yes, you should know that everyday life, you take a little less than normal. I mean, if you are pushing yourself to 100% full, take it to 75%. You love the food, but then it should be 75%. Your intestines need some time. Your heart needs that time. Your heart pumping should not be more. And then when to exercise. Exercise is a very important thing. But then how much to exercise, when to exercise. Marathon, everybody cannot be marathon, players. They cannot be athletes. So you have to individualize. So here the personalized medicine comes in, that individualization of food, diet, nutrition, and drugs. Everything is balanced. So here, integrative medicine, which I am wanting to do in my place, is integrative medicine. So this involves yoga, naturopathy, exercises, your mind de-stressing, and drugs. And the diagnosis, right kind of diagnosis, which has to be very precise. And even if we tell a cancer patient that you are getting better, he certainly gets better. There's no doubt about that. One doctor comes and tells a patient, tomorrow you're going to die. Even if he can live for another 6 months, he is going to start thinking, oh, when am I going to die? So he's going to go into that depressive mode, which is going to increase his inflammatory markers in your body. The inflammation is going to aggravate the underlying cancer. So everything. So inflammation, stress, these things are the most important things in your body that aggravate the underlying viruses or the bacteria or the cancer. So these drugs help certainly. But then I always tell the patient, you should do 30-minute exercise every day. That means walking, not more than that. And even if you're tired, but only you should not have fever. You do not need any rest. Take adequate fluids, because adequate fluid means that your body is pumped up, and it requires, yes, if you have a heart failure, again the management part comes. The fluid has to be restricted, but to some extent. How to take a bath, and then you know that, okay, even in heart failure, these drugs are helping out. So my study has not been blinded, but yes, I want to integrate, because people believe in Ayurveda, and Ayurveda is all about plants and their derivatives. Only thing is, we've not done research on that. We've not done what is appropriate. How much is appropriate? Can it create toxicity like the other drugs? So this is the only thing that is, and I'm sure our government can do it. And I'm sure it doesn't require any funding. Very few. Everything is available. The neem leaves are available. The tulsi leaves are available. This country is full of, nature. Only thing is, we are not exploring it first. And secondly, when we talk about these repurposed drugs, especially azithromycin, or we are talking about ceftriaxones, or we are talking about pentoxifylline, or Dexas, and stuff like that, we do not really need too much of funding, because this is not a new drug development. This is a repurposed drug which we are trying to utilize, like pentoxifylline and itraconazole. We can give to patients, and it's so reasonable. We can give to 1,000 patients and see the effect. If they are having lung issues, even in lung cancers, we can give. We can only see if there is an interaction of other drugs and give it to the patient. It's peanuts, even the prices. So where does the funding come about? Funding only requires when we have to especially establish a newer molecule, a monoclonal antibody, and restart from the different perspective. Then we require a funding. That, I think America is very good at it. We can do it.
Yeah, recently I think I've started seeing that there are quite a lot of trials that are done even on Ayurvedic medicines, and I think that was very promising to see that, if we can show that this can go through the same stringent ways of getting these approved, I think that faith in Ayurveda will probably be a lot more established from people across the.
Because we need optimization of drugs, basically. So like we optimize the dosages. How we optimize the dosages is, we again give it to the patients. We make controls, we make cases, and then we try and see, even for the optimization, that this much. Like a recent patient, for example, required the double dose of, in fact, the toxic dose of pentoxifylline, and he was okay. He didn't have any effect. So that is when we decide how much is necessary. But for that, we need, again, studies. We need molecular studies for that. So molecular studies would be a little like if we involve NGS in this, next gen sequencing, or we are involving arrays, or we are involving some chromosomal studies. So these could be expensive, because, genetics is expensive. So, but if
not that much anymore, right? I mean, now it's become cheaper.
We are trying, and you will be doing it much better. So, but whatever the answers I got when I set up this lab in the Anand Medical College, and I found patients coming to me and asking me that, do they really require to do a BRCA1 and a BRCA2 when they're already diagnosed with a breast cancer? So, when we do it later, so preventive, everybody is ready. So yes. I would tell that your family requires it. It could be an autosomal dominant disorder. It could be autosomal recessive disorder. We don't know. It could be epigenetic phenomena, because we don't know if nobody in your family is having, only you are having, but that phenomena is translating into a permanent generational issue. So we really don't know. So when we are blinded, we should get it done. So that was the only thing why they got it done in families. But otherwise, a BRCA1, BRCA2 would cost like 30,000 minimum. and they would not want it. So that is why sometimes the targeted genetics is expensive, but they are not worried to give the money for that, but they are worried that it will go waste because the treatment is the same. There's no change. So that is why.
Yeah. So I think, one of the reasons why we chose preventative space was that at least, the two things, right? One is that you can actually get people to be aware. And I think in the US, for instance, BRCA 1 and 2 brought down the cases of made it detect breast cancer very, very early and reduced it by almost 90%. And I think that's the area that I feel that, it's more important to be able to address the prevention space rather
than prevention. Yes.
But the second thing that we've also seen, for instance, is that if the genetic analysis allows them to be able to change the treatment course, I think they're very keen on doing it. If it doesn't, then I think it can only be used as something that you can use as a diagnosis for your future generations or for the rest of the family. And I think that's where it is limited. But one of the good things I think has been that genetics is now seeing quite a reduction, and one of the reasons, like we sat with a lot of doctors to understand why is it that doctors end up recommending a genetic test in the end when they could have done it earlier and saved lives. We found out, and I think you are confirming that people were asking, one is, why is it expensive? What do I get value out of it? So I think one of the analysis that we did was to say that if you could do it at a low cost and do it upfront, would it really have a return on investment? And I think that is what we saw, that if we could make it at a price point where they don't feel like they are, taking out the whole bag, then I think they are more willing to do that. And I think that has been our effort to bring down the cost
substantially. And that will help in the research as well, because we'll have lots of data, and that data would help us in isolating many issues which we have not focused on. In fact, I would say the whole world is trying, but there are certain things that we could do because of this molecular and the genetics both together. The molecular level and the genetic part starts from there, the cell and the genetics. So cellular genetics, when we talk about, we are talking again, where the DNA is broken, what the methylation is doing, why epigenetics. Now, epigenetics is very much all connected with your stress. The stress of the body, the stress of your environment. The environment has so much of dirt and so much of smoke and so much of, that's also doing its job. So the diet, the organophosphorus compounds which have been sprayed on your vegetables. If I say somebody, okay, take your vegetables, again, there's no, a particular person came to me and he goes, you are saying, but we are vegetarians. So why did we develop colon cancer? So that is a big question, that when you're vegetarian and you're only eating, and some vegans also, they never had probably even had milk. So they said, how could we get? So again, question stays that so much of irresponsible behavior. I think the government should be acting on that. There should be some restrictions on the dosages of how much organophosphorus compounds you are going to use as sprays, and random using should not be allowed. And especially the environment has to be clean. The cars, like in Singapore, the cars are less, so the smoke is less. So again, the lung cancer would be less. Like Delhi is in a bad shape with all of the air pollution. So the pollutants have to be controlled. There is lots to be done. But again, telling you these things also have a major role in getting all of the diseases per se. So I guess that's very important aspect of the disease part.
I agree, and I think it sort of reminds me of a story when we went to a temple with my dad, and one of the things the Pandit asked him, said, what do you wish? And one of the things he told was that I wish for world peace or something of that sort, right? Basically saying that I want everybody to be happy. And then he said, no, I want you to tell me what you want for yourself. And one of the things he told me was that, he told all of us was that if the world is happy, I'm part of the world, and therefore, but if you wish only for yourself, I think, and that's what happens, when you say increased pollution, increased everything, is because everybody starts looking at them as being individuals rather than being part of an ecosystem.
Definitely.
So I think that adds to the pollution and everything else that sort of ultimately is affecting all of us, but we don't think about it as, that we are doing something with the climate change, we're doing something with pollution and all of that. So I think that's fascinating. So we also, I think we've talked about a little bit about the epigenetics. We've talked about sequencing and all of that. There's also this lot of new work that is happening on the gut microbiome, and I think you've done some work on that as well. So what how important do you think the gut microbiome is, and where are we today? Do you think it's something that everybody can do or not? We are not yet there.
See, the gut microbiome is more like we are studying the viruses, the common viruses, which are the normal commensals of your gut. That are required by your gut is the bacteria, like the H. pylori is in the gastric mucosa. So if you don't have it, you may land up, again, we had a research where you can land up with cancer, with gastric cancers. And so some gut microbiome, when we talk about a microbiome, it's all about microbial genetics. It's all the important viruses, the important bacteria that have to be there in the body. And sometimes those alterations, the DNA alters in those viruses and creates diseases. And those particular diseases, like the inflammatory autoimmune diseases or certain things, we are trying to study. So maybe the diseases that like cancer, autoimmune, you can say the inflammatory bowel disease, IBDs, those can be studied very well. People are also studying multiple sclerosis as one of the in the areas for gut microbiome, and implicating the gut microbiome as one of the causes for multiple sclerosis. But let's see the results. But yes, we can always look into especially the frequency of stools, and sometimes the patient comes, I'm constipated without any cause. So those can be studied very easily. And the diarrhea part, person has an anxiety, he has diarrhea. So you can always study that as a microbiome. And microbiome requires either the proteins isolation or the NGS, which we can use for that. So, but it's still a very low level. I think it has to be more. But once we isolate it and we are able to do it, maybe that helps out. It's still in the research level and the very basic level 1, I must say. So it has to be more pronounced. But yes, certainly I think that it's not about per se the viruses, it's about inflammation. Why the colon cancer is coming up so much. Either is it an alteration in your gut, and then why your eating habits are going to get affected, especially when you're taking that fatty diet. We are taking burgers, and we are not taking fibers. So the fiber is required for just not peristalsis, but for the healthy intestines, for the healthy microbiome also. So the microbiomes do play a very major role. But when we start diagnosing through the microbiome, that I think it will take some time. And so let's see how much time it takes. It's still in the pipeline.
Sure. So I think since you worked extensively in COVID, I think I got a couple of questions. Was that, one of the things when we analyzed the data, for instance, for a large number of our own, customers who had COVID, for instance, we found that different people reacted differently based on their genetic makeup. was there anything that you found in general, if you did an analysis of your patients who were diagnosed with COVID, was there anything that you found which showed that, people with a certain kind of genetic makeup will have longer term COVID? And was there any analysis on that done at all? Or what do you think? How do you think we can study, diseases like COVID using genetics in a far better way, other than the fact that we did post-genetics, understanding of human response to the virus? But are there any other things that we could have done which could have potentially helped in either development of new diseases, new drugs, or in a better understanding of the disease itself?
The COVID, you mean?
Yeah. Yeah. Or let's say, if there was something else in the future sometime, what should we be doing as a genomics company to be able to really see how we can contribute more effectively in terms of better understanding of any new virus or any new bio threat that might come in?
So actually, I think that first and foremost is the severity. We have to understand one patient is not like the other patient. Like the funny part is that we are doing the vaccines. We need vaccines for severe patients. Maybe the normal milder patients are just recovering all by themselves. And again, the natural immunity, which is your adaptive immunity and the T cell immunity, basically that is helping. But then that immunity is playing again a negative role too, because the virus, it is attacking your lungs, and that is what we are stopping. And that is the severity of a patient, that where your own immunity is affecting the patient's, the lungs or any pathway which the COVID takes. So the COVID, basically, when we are checking it, it's in the receptors. We call them ANG receptors or the angiopoietin receptors. So it goes there. So here we can stop the angiopoietin, and there is a drug which is done for the cancer ovary, the final stages. It's being tried. I wanted that, but then that is being studied for that. Maybe we can do that. We can do that kind of a study on COVID patients, and those kind of things we need to isolate. But so when we are talking about the bio threat, or we are talking about any other, we have to first understand what the threat is all about, and if that threat really is going to get affected, about our bodies, we have to understand. You as a diagnostic center will, if you really want to delve into their problems, you will have to see what they are, those people are like. First, their demeanor, their overall severity of any disease which they are picking up. So that if once a patient becomes a cancer patient, for that matter, he is automatically a weak, his constitution is weak. So we need to study that. So studying all over the dietary things, the nutritional things, you need to put up those patients into a proper diet. So everything has to be balanced. The drugs alone do not function as good as when they are managed with other things like activity. Your children need to get away from these mobiles and these games. They have to go out, like actively getting a fresh oxygen, early morning, getting up, doing your exercises, and those will really help you along with the diet, along with the stress and everything. So these kind of things, I personally feel that we need to understand, and then only we can go further for any disease or any bio threat which you are talking about or whatever. So this is how I feel is the most important thing for us to in future, even for COVID, even for any other disease which comes up, like as a pandemic, we need to understand individual patient. So personalized medicine will play a role today or tomorrow, but we need to work on that. If India can work it, it's well and good. We understand, okay, we can make you as expert in your lab, you can design certain tests which tell us how the health is, along with the normal blood test. Like nowadays, all these blood, these companies are having packages and all that. Some packages are useless, but yes, certainly you understand, okay, these, the diabetic patient is there. Okay, there is a pre-diabetic issue. So it's ultimately going to lead on to diabetes, or type 1 diabetes is there. So lifestyle again, some are lifestyle, some are inherited. So if it's inherited, you have to be very careful from the very beginning. So that way. And if we change the lifestyle, if we are making a child more, what happens is, as humans, we focus so much on the disease or the weak person that we try to overpower him. So that's a humanity part. So that is one negative thing which is leading on to all of this. One person wants to become rich, nobody understands that's also stress. And we are, forcing ourselves into being that. So if we are relaxed, if we don't care, doesn't matter, okay, fun. We are, of course, we try towards the end. Like I saw many doctors, they worked very hard, but then in the end, when they developed COVID, some were very severe and some died. Like one of our IMA head, he died, Dr. K.K. Talwar, Agarwal. And so he died. And it was, again, what? You are still, he had...
Dr. Kler, I guess she's probably on a call or something. But meanwhile, I think maybe what I can use this is that, we've been doing most of the work that we do in Mapmygenome has been around preventative genomics. And we have, like Dr. Kler was mentioning, we have combined now genetics with biochemistry, and have opened up labs across the country, both in Bangalore, in Delhi, and in Hyderabad. So I think our aim really has always been towards how do we empower people to move towards a more preventative lifestyle rather than not. So I think we might have, I don't know if Dr. Kler is job, but we're almost at the end of the hour. So what I will do is, if she doesn't join in the next 2 minutes, I will conclude the session. But I just wanted to maybe just give a little background that what we do with Genome Patri is exactly what Dr. Kler was mentioning, which was to look at somebody as a holistic view. So look at the genetics, look at their why they are the way they are, what causes disease, but also what will keep you healthy, and why do how do you lose weight, how do you keep fit, and so on. And we combine that with the regular blood tests so that it actually helps you in understanding what is going on. Okay, she is logging back in. So till then, I will use this time to also say that Mapmygenome is also doing a lot of work on clinical genetics. That includes looking at oncology and mother and child. And we have a lot of very low-cost panels, because we believe that if we can empower the patient and the doctors by creating the right priced products that are of value to them, then it allows us to be able to then bring out the best for the patients that the doctors need. So I think we are probably getting back Dr. Kler online, and just to conclude that thought, I think we are able to put all of these pieces together and be able to give the right kind of tools for the medical professionals to be able to use. I think, Dr. Kler, we can't see you, but I think looks like you've joined back on.
Yeah, hi. Actually, I don't know, something happened with my... Yeah.
I use this time to talk about Mapmygenome, so it is perfectly fine.
Okay.
So,
okay.
Yeah.
Okay.
Yeah. So I forgot now what was. I think the discussion we were having was okay. Let me ask you one question that a young doctor has asked. Right? Said that it's very commendable that you moved. You were able to move from being a MBBS doctor towards towards a PhD. Is there any set of some advice that you would give younger doctors who want to do the same thing that you are doing, which is to actually do a PhD, and what areas should they be considering, and what is the easiest starting point for them to be able to start understanding what genomics is all about? Because according to this young doctor said that we really didn't have more than 2-3 pages of genetics during our MBBS course.
Certainly. Actually, it's not about having patients as genetics. It's about all patients. You have to understand that we are seeing all patients. When a patient comes into the OPD, you start watching him. The most important is, as a clinician, I advise all the younger doctors how to take a history taking, which is very, very important. And from a history of a patient, and from his walks, and from the way he sits, from the way he speaks, you can make out 50% of a diagnosis. That lies on your blood test. But if you are not vigilant, if you are not observant, you are not going to be very good clinician, firstly. And secondly, in a history, when a patient comes to you with pain, you have to ask all about the pain. Where it started, when did it start, how much is it, and so on. There are protocols about the pain. And when we are talking about shortness of breath, especially like when COVID comes up, how I can tell, okay, this patient is a COVID without getting his RT-PCR. So when he tells me that I am having fever, or I'm not having fever, but I'm having a milder cough, or I'm having a stomach upset, and I'm not feeling very fatigued today, but yesterday I was. So why? If you were feeling or having fever yesterday, why today suddenly your body is high, and within a week again your body is going to get bad again? So that way you have to understand where and what all questions you have to put up. And then where genetics comes is when we understand that yes, these patients are getting okay and not contracting the disease again, but these very patients, another set of patients is having the same symptoms, but then contracting the disease a very severe way, or a moderate, and having fever at the 6th day or the 10th day. And why? Because that is genetics. That has nothing to do with a virus getting more in your body or less. We have to understand the viral load alone doesn't matter. It's the severity is how much the virus is destroying your pathway. And that is genetics. So if a doctor wants to do it, he has to understand right there that, okay, once I do, the patient is coming to me, he is a heart patient. And even if you are diagnosing a heart patient, you will automatically come to know that he is having some shortness while walking, or he was having some pre-syncope, or he was having some unconscious episode with a heart block, or let's say type 2 diabetes, he was having early morning headaches. So many things they have to understand, that diabetes, what symptoms they have to watch. For heart disease, what symptoms they have to watch. For neurological disorders, what symptoms. So if we talk about COVID, there is something called GBS. Doctors will certainly understand. So this is also one of the common things which happen. So these kind of things they have to understand. And yes, if we start with genetics, it's going to be wonderful, because a mixture of the medicine and genetics, it's going to be wonderful. Why? Because we can catch up all areas, and genetics is everywhere. It's not just limited to pediatrics or gynae. It has to go beyond, and it is beyond that. It is at your molecular level. When we talk about genes, when we talk about enzymes, they should be focused more on biochemistry. If they want to do virology, they should be more focused on the microbial or the microbiology. So the basic subjects they should be concentrating more. Medicine should be going along with. So when we talk about that, the clinical medicine, then they can become experts in both. So because if they want to do virology, they will have to go through pathology. So once you are doing pathology, obviously the viruses is a very specialized branch. And for me, I personally always say, go from the basics. Like when I read about COVID, for that matter, I was not a virologist, but I now know all about viruses. And when we talk about positive sense viruses or the negative sense viruses, what are they? Why the positive sense viruses generally give so much of bad diseases like SARS-CoV-2. So that is how it is more important to understand what those viruses do in your body, and at the cell level, what they are doing, and how their genetics and your genetics match up, and how the immunity, how they evade your immunity and attack your body. So basically, it's the evasion. How do they do it? They modify their own protein, like your protein, so that the body is unable to understand that there's a foreign body coming in your body. And immunity has a role when a foreign body comes, foreign organism comes, it attacks. Now, and in the end, when the virus is all over your lungs or your vessels, suddenly the immunity gets up and attacks your body. So that's how you have to understand. So the immunology part is also there. So they can read the immunopathogenesis of each and every disease. First, understand what is immunity. When we are talking about vaccines, or we are talking about how immunity is important in all diseases, or when we are talking about COVID, is it important? What if we are talking, okay, what is a function of each and every immunity part, like a toll-like receptor? Now, the toll-like receptor immunity is very important, but in COVID, we have to inhibit that immunity. Otherwise, severity comes up. So, like these three drugs inhibit that TLR, the toll-like receptor. So that is how we save patients. So everything has a meaning. So once a doctor wants to do, he should focus on these microbiology, biochemistry, even anatomy for that matter, understand the physiology of the body completely. Everything is interrelated. So once you understand the physiology, you are doing your microbiology or virology, everything, the basic when we talk. Clinical medicine will help you much more, and then you can go in for genetics. But the PhD part is much better, according to me. I have never been interested in the MD medical genetics.
But do you think that we can make some, like, include something in the MBBS program itself for
Certainly. We can do microbial genetics, which is, again, you were talking about the microbiome, and all about viruses, all about bacterial genetics. So everything can be included, because everything has an importance. When we talk about virus, now that when we say, okay, this virus is made in the lab, how can it be made in the lab? Again, what we are doing is we are generating that virus. Mm-hmm. That particular virus is getting in the cells. The replication is happening. From where does the replication come? How can it replicate? In your body, it replicates much more than it replicates in another body. Like when we talk about HIV in Africans is, they have immunity for that. So these kind of things, again, genetics. What we are talking about is genetics. So if we include genetics in microbiology, in biochemistry, in even the physiological part, physiology is basically studying your own body. So once we study, we understand, okay, this part can be understood and genetics can be applied. So that way, it's a very, I feel personally that we can include, but we need expertise in understanding and expertise in knowing the different cycles. Like biochemistry was some, I'm sure the younger doctors are going to totally agree how boring biochemistry was. So,
yeah, so I find it exciting more because I look at it from a data point of view.
Yes. But now I know, but when I was younger, I used to hate, I don't know how it was so difficult to, do biochemistry, and it was the worst. Microbiology still was better. But again, biochemistry is the understanding of the biochemical pathways, which are again very important for genetics. So I feel that genetics should be a separate branch, but involving all these.
Absolutely.
So, yeah. And we need expertise in making young doctors or young students to understand, and so that they can apply it further. And it's not just limited to pediatrics or gynecology.
I think the same maybe should be true in people who are doing, a bachelor in biotechnology, to make it a little bit more closer towards the field of medicine, closer towards, so I think that way we can start bridging the gap. And I guess we have a lot of online courses that are available that hopefully people can get to. And one of the things that we are trying to develop at Mapmygenome is to create like this whole genetic counseling, some sort of a course that will help people understand and try to make it simple enough so that, at least it's not as complicated as it, I think for a lot of people, they don't want to know about it because it's too complex. And I think part of the problem with science and others is that our communication has been a little complex, right? I mean, and I think if we can break it down, and like you said, if we can go down to the basic level and start to understand, I think that really helps us quite a bit. So
yeah, certainly. Actually, genetic counseling is, I feel that it should be left on to the patient or his family. And if I saw that they were very much interested in the pedigree analysis, and then what we can do is we can always make the students understand the different symbols, understanding how to make a pedigree, the 3 generation, and how to understand when epigenetics comes into the role, other than these X-linked and autosomal or the skip generations in autosomal recessive, and then understanding the Mendelian. See, it starts from the Mendelian inheritance, and then it goes forward, and how dwarf or different hair colors, and which is dominant, which is alleles, what are alleles. So doctors don't understand what are alleles, what are heterozygous, what are homozygous, wild or disease. Even the wildest homozygous could cause a disease. So according to me, which I found. So that is how the genetics is. It's interesting, but it needs to be understood. Every protein in your body can be understood through genetics. The real part is that when we talk about obesity, adipocytokines are there, leptin and adiponectin. So when we measure their plasma levels as doctors, we do understand, but there is lots to understand if those are affecting the heart disease or the stroke or ischemic, like, is it affecting? It's very interesting actually. So different people are fat, they don't develop anything. Even the COVID thing, I found some fat people never had any COVID, but there were certain very thin people who were badly affected. So, that way. So everything has its role. So, but this is only isolated through genetics. So that is how I feel the younger generation definitely should go in and pitch in as doctors. They should certainly, because this is going to help in diagnosing and treating a patient more accurately than what they are doing. Yeah.
So since you mentioned alleles, I thought I'll recite to you a small poem I wrote on alleles. So it's called Amorphous Alleles. There was once a gene with so many alleles that if you looked at one, you hoped to run, unlike the other one who seemed to be having fun. It was just another day. I met them both on the way. They came to a locus and fought till they went out of focus, were the dominant one in the heterozygous race that had just begun. Yet the recessive one smiled. Its phenotype was being filed for the future to come. The future it came when the wild one was tamed, and the mutant was the one that completely changed the game.
Yeah. Wonderful.
So I think it has been absolutely wonderful chatting with you. And I know it's been a little bit more than an hour and 15 minutes. So I don't want to take up more of your time. But it has been absolutely fantastic. Your journey has been inspiring. I think, both in terms of, how much of breadth you've covered, but also what personal struggles you've gone through in terms of being a patient yourself.
Yes.
The kind of vastness of you've looked at patients who are COVID patients, you've also looked at patients who are in Ayurveda, you've looked at oncology, and you've looked at geriatric patients. So I think it's a fascinating journey that you've been. So I'm really, really happy that you were able to spend the time with us today to give us all of your time and your expertise. So I'm really thankful to you. And
welcome,
I will get to meet you in person sometime.
Surely.
But I think for that we'll have to wait for COVID to sort of take in. But if there's something else that you'd like to add, or I'd like to close the session.
I only want that at the moment that these drugs should be started in India, so that we are the pioneers in starting, and there is a complete treatment for this. So I have patients, and those can tell you or tell the government how they have, because they come back to me every time. So we can start off targeted vaccines for that. And India can be the leader for, as a team if we work, because I cannot work much. I can only take because I was doing telemedicine, and through the telemedicine, WhatsApp, and I would get there, the management part also. So I managed, but then we had a team of monitors, the volunteers who wanted to help. So we had lots of patients who were from army background, who were in Delhi, and Delhi was badly affected. And I would rather want that these drugs, if even in for that matter, Punjab. So that is why I wrote this paper, so that it can go way ahead. Now it's in Europe, PMC also. Europe PMC wanted this as a preprint, because these are case reports. So I would certainly request bigger institutes or the government, particularly ICMR, to start with the research trials, especially the random RCTs, control trials, especially if the wave comes or whatever they want to, because the cellular study which I wanted to do, I got it done in Chandigarh. Dr. Deepak, who is again in a CSI institute, he happened to do it for me, but it was not formalized. So we could always formalize that. And then we could do the RCTs, the cell culture, the case reports, the case series, which I have done since 2020 and 2021, and with the Delta variant. The Omicron variant I just gave, I didn't take up any cases, but yes, I do have their data and everything with me. And I would want that, especially the ICMR, the government focuses on that. And we, rather than, waiting for America or Australia to come up with, because we do have brains here. So we can function and together as teams. And because without a teamwork, I think there's no point in one person just telling, and the team has to be there, and which functions and which goes ahead with, and these drugs do not cost anything. The best part is that it can be in the rural society also. They can, be given free of cost also. So that is also one thing which we require as Indians, so that the poor community, the BP below poverty line, at least they benefit from these diseases, and nobody dies. Main importance is that we can save the society. So this is my very, you can say, an appeal or whatever, because I have seen this in more than 1,000 patients, and all are well, all are doing good, but severe patients are doing much better, honestly, because they were so petrified, because they were severe. Now, when they are walking and they are, just normal, having no residual effect of COVID, obviously they're going to be very happy. So that is how I want that at least the Indian society helps. Although I've given this paper outside, so let's hope the world gets it, how these drugs are going to get affected, and how they can generate, because FDA has already banned pentoxifylline, but India still has. So we can, start making more of pentoxifylline, which is a very good drug, a safe drug, which has no side effects. And let's hope for the best. I am trying my level best at this end. And so if everybody can just pitch in. So this is what I would like to say, especially in this pandemic.
Thank you. Thank you so much. And we are hoping that, we like you want, we would like, the drugs to be available. I'm obviously not a trained or qualified medical expert on that matter like you, but I think certainly, I think we would like for India to have the capability to come up with drugs.
Yeah, and these are repurposed drugs, and these can be used. We do not need anybody's expertise, or monoclonal antibodies are not required for us. These are just normal drugs which we have used for this purpose. So, and these are effective, and so that is it. It was wonderful actually, interacting with you and the questions and everything. Anything else, I'm always available.
Thank you so much.
Yeah.